Audible? Yeah. So, good morning, everyone. First of all, I would like to thank all of you for coming so early in the morning. And one more thing, I can see you all sitting, many of you sitting on the back side. So, please come forward. The empty seats are there in the front. Whoever is sitting at the back, please come forward. Come, I am watching you all. Come. Come forward, come sit in front rows. No problem with that. They can have their breakfast sitting in the front row. So we'll be starting with a case. This is a 44-year-old gentleman who is presented with severe heartburn. He was on PPI for I think 2-3 years without any. When he is taking PPI, the symptom gets relieved, but whenever he is not taking that, the symptom recurs. So he was evaluated by medical gastroenterologist. He went to many places, and then one endoscopy was done by a medical gastroenterologist. He said, it was found that there is evidence of severe GERD with Barrett's esophagitis, and then there is lax LES with Hill's grade 2 hiatus hernia. So he came to me for further management, and I did a esophageal manometry which was normal, and I did a 24-hour esophageal pH study. The GERD, I mean the Demister score came as 31, which indicates that there is pathological reflux. So GERD, Demister score normally is less than 14. He was having gas on. So he was having 31 Demister score. So I prepared him for, I counseled him that you need fundoplication, and that will relieve your symptoms. So he had a history of laparoscopic cholecystectomy in the past, and no other significant history. And hypertensive, he is on regular medicines. So now, if you see the OT setup, so I am just standing on the left side of the patient. Monitor is on head and side, and patient is in leg split position, supine with leg split. Arms are abducted. So first of all, pneumoperitoneum creation. So this is, just hold it. Yeah. So suppose this is Jiffy sternum. If you can see the outside is visible to you. So if outside visualization is clear to you.
Yes, sir.
So this is Jiffy sternum, this is symphysis pubis. What I do is I don't go by the umbilicus. So I divide the distance in 3 equal portion. So this is the 3 equal portion. Okay. So upper 1/3 and lower 2/3. So at the junction of upper 1/3 and lower 2/3, just off the right side of the midline, I started creating pneumoperitoneum with Viris needle. So this is the first thing. So you can see the abdomen is getting distended gradually. So there are standard 5-port technique for most of the upper GI cases, hiatal cases, upper GI cases, gastrectomies are there. So mostly these port positions will be used. 1 port at the site of Viris needle, that will be my camera port. Then there will be another port in the, after going inside I will show you how to plan the other ports. So one in the left subcostal region at the mid-clavicular, in and around mid-clavicular line, one anterior axillary line, then on the left side, and one in the epigastric region for liver retraction. So pneumo 15 pressure has been created. Then I will go inside 10 sharp rocker. ये भी खोल दीजिए, ये लग जाएगा. Okay, camera, light off, top light off, camera, গরম জল দে, এই লাইটটা সরিয়ে দাও. মপ দে, হেড আপ করতে হবে ভালো করে, আমি বলবো ঠিক। So I'm going inside. So this is the first port. Okay, this is the monitor in the head end side. Okay, this is the position of the patient. So leg split, I am standing now, I have come in between the legs of the patient, standing between the legs, and I am going inside now. Yeah. So first of all, as I said yesterday also, so do a diagnostic laparoscopy. See, everything is around. First thing is to see just below the viris, is there any injury while putting the viris inside? So nothing as such. So this, you can see the left lobe of liver, the stomach, okay, and I will ask Ovaida to Ovaida, head up karo. So team anesthesia, we have Dr. Priyangshu and team, and with me আরো ভালো করে হেড আপ করো, বলো করো আমি বলবো, বাস একটু লেফট আপ করে দাও। So steep head up, left up, steep head up and little bit of left up, bas, that's it. So that is my position. So it will now hold it. Now I'll put a epigastric port for the liver retraction. So with me in the camera, Dr. Shashi is there. He is our senior surgical registrar. So he will be assisting me with the camera, and for retraction you need a surgeon who can retract the omentum, then the while doing the dissection, the liver retractor there. So for that Dr. Rohit is there, fan blade liver retractor. ঘুরছে কোনটা গোরা, চল ঢোকা বন্ধ কর। So liver retraction you can do it with any laparoscopic instrument, but here I am using a right side. Yeah, here I am using a fan blade liver retractor. खोल देखिए, खोल आ जाइए, अंदर आ जाइए, खोल खोल, अरे घोरा मालटा तारपर तो खुलबी, हाँ खोल। Yes, you can see after going inside we can rotate the instrument to split it, open up down, door, hold kor, ठीक है। Now you can have a look at the hiatal area, okay, the stomach, fundus, the body and the antrum. Now you can plan your rest of the ports. So this is like incisura angularis. So just opposite to the incisura angularis you have to place your next port, that is the right hand working port, 7 millimeter port. So here just subcostal position, right hand working port just opposite to the incisura angularis. So here the preoperative, don't do ekdam fixed preoperative planning that I will put my ports here. Rather after going inside, seeing the intraoperative findings, then you can plan your ports accordingly. Then you will be able to adjust. Sometimes it is, if you plan it beforehand and then after going inside you sometimes you may find it difficult to the port. हाँ ठीक है, ওটা আমি ঠিক করে নেব, আপাতত থাকে এরকম, ঠিক আছে। Then there will be one retraction port that we have to put. So it will be far laterally here. So this will be the retraction for the surgeon who is assisting me with the retraction. 5 এটা 7 তো, হ্যাঁ 7 দিতে বললাম। ঠিক আছে থাক, আর 5 আছে, বললাম তো তোকে 7টা দিতে, হ্যাঁ। So I'll be using two, हाँ, this is right hand working port. I prefer to use 7 millimeter. So is 7 millimeter, then 5 millimeter, then the left hand working instrument. So here is falciform ligament. So you have to place a little bit, you have to plan your position, the port, so that the port will not fight with the port, or instrument will fight with the falciform ligament. Hold. Sometimes you will find bulky falciform ligament which is sometimes difficult to manage. You will coming inside with the last port. नोट चेक देखिए धर ठीक है. So all the ports are placed. So now धर hold. हाँ आई liver retraction तो नहीं है. Yes. So gentle liver retraction like this. Okay. So your scrub nurse who is there, he is supposed to give the retraction. Just hold that. যেরকম করে আলতো করে হোল্ড করে আছে সেইভাবে, ঠিক আছে, not too much pressure. Okay. So Mr. Suraj is there who is assisting me.
Sir, can you show all the port positions from outside?
Yeah, I'll show you. So I'll just change the gas. It was in the camera port. So gas inlet is now in the assistant working port. So I'll show you the outside view. So these are my 5 ports. This is liver retraction. This is right hand. This is surgeon's retraction port. This is left hand working port. This is camera. Much above the umbilicus, as you can see. Okay, jol, gorom jol. Yeah, please. So meanwhile, I start doing. There is another case is getting induced. Right inguinal hernia. Dr. Vikram will tell you the details about it. Dr. Ram is going to operate on that patient. To Sonu ke tako. চলো হোল্ড দে বাদ দে ভাগ করে করে দাও. দুটো ওটি মিলিয়ে. হ্যাঁ ঠিক আছে ঠিক আছে. হ্যালো হারমোনিক. হ্যাঁ ওকে একটা বাবল গ্রাসপার দাও. হ্যাঁ তাকেই তো ডাকলো. শোনো ম্যাডাম নেই. আচ্ছা এইটা একটু তুলে দে উপরে. ধর এটাকে উপরে এরকম ঘুরিয়ে রাখবি, ঠিক আছে? এটা কিন্তু মাঝে মাঝে ডিস্টার্ব করবে. ওকে. সো ফার্স্ট থিং ইজ টু ইউ গিভ টু retraction of this like that. Fundus retraction is important like that. You have to give a retraction. Hold it. So Dr. Rohit is holding that with good traction. Okay. Just hold it. Okay. Give downward traction. Yeah. So Dr. Rohit is our DNB first year surgery PGT. Come close. Yes. So this is the pars flaccida. This is a gastrohepatic ligament. This is a pars flaccida. First thing is to just show me down. Keep it in the center. Yeah. So with harmonic shears, you can use monopolar, hook also to divide it. But harmonic is a very good instrument. You can take advantage of it. So once you divide the pars flaccida, you will be able to see the right crus. See, this is the right crus. So right crus is clearly visible. So along the direction of the pars flaccida, you keep on dividing, you will get the phrenoesophageal membrane. So you will be approaching towards the hiatus, and then you will be dividing the phrenoesophageal membrane like that. Come close. Yes. দিয়ে দাও.
Hello. Hi, good morning, Jaydat.
Good morning, sir. You are audible. Go ahead.
Yeah. So, good morning, all the delegates. And today's case is a right-sided direct inguinal hernia in a 63-year-old male. And we are going to do a TEP repair, totally extraperitoneal repair for this patient. Okay. So, in this patient, the position is supine position. Okay, this is the umbilicus. I have not marked, but hernia is on the right side. Okay, and clinically and imaging wise, there is no hernia on the left side. So we are going to do a right TEP. Now, the first step is most important in TEP. That is primary trocar placement and creation of extraperitoneal space. Right. So I'm going to start So we make a horizontal incision at the lower lip of umbilicus. Okay. At the lower lip of umbilicus, we make a horizontal or little curved incision of around 12 mm. Okay. You can come on the head end. So we are showing it through a laparoscopic camera. Okay, like this. So after incision, we dissect the subcutaneous tissues. सर मेरे स्पेक्स हटा दीजिए, ये थोड़ा नियर विजन का प्रॉब्लम, नहीं नियर विजन प्रॉब्लम. Okay, and take this retractor, this S-shaped retractors, its diameter is 10 mm, and retract the anti-abdominal wall. Try to see inside. Okay. Yes. So there are still some subcutaneous tissues, and we'll try to identify the anterior rectus sheath. Though this white color structure is anterior rectus sheath. Okay. So the anterior rectus sheath is visible now. Okay. Then I'll give a nick onto the anterior rectus sheath. Some bleeding. Okay. And with the help of artery forceps, I am retracting the right rectus muscle and trying to, one second. Sorry. Yes. Here you can see the nick. I think let me clean inside. Okay. So the rectus muscle is visible to me, though it is difficult to show. Yes. Okay. And I'm retracting and posteriorly we can see the posterior rectus sheath glistening white. And then I want to take everything up. Okay. And here we can see the posterior rectus sheath behind. Okay. Fine. So so we have reached the extraperitoneal space. Okay. Inside, and let me place the trocar. Okay, remove this. Okay, I am using a 10 mm trocar. It should have this oblique cut. Okay, and place in the extraperitoneal space. Now wet gauge piece, please. Now we'll pack the space with a wet gauge piece. Yes, show it. Yes. To avoid having any subcutaneous emphysema. Okay. Silk 1 number. And then fix the trocar with the skin. Okay. You take a round at this point so that trocar does not come out. Okay. So the trocar placement is done. Now we have to confirm that we are at the right place. Okay. So as you saw yesterday also, that we connect the gas but do not start gas. Okay. We first go inside. Give me hot water. We go first inside and confirm, and then we'll start insufflation under vision. Okay, so you can see the posterior rectus sheath below. Okay, yes. Guess start please. No problem. Okay, and I just opened the gas, and gas is filling in the preperitoneal or retrorectal space here. Okay, now next step is to create space by scope dissection. Some people use balloon for this this step, but we do this dissection with the help of scope. I have taken a 0 degree scope. So through 0 degree scope we get a end on view, and now we proceed with the space creation. Flow rate 20 कर दो, flow rate 20 कर दो. सर मेरे specs लगा दे, specs. Yeah. So you can see how the CO2 is helping us. थोड़ा ऊपर. One second. Yeah. Fine. Sorry. Yeah. So how the CO2 is helping us getting a retrorectus space here. Okay. So we make small to and fro movement to have this space. Do not make very violent side to side movement, otherwise these small vessels they break, and you have very bloody field, which will be
pressure is 14 to 16.
difficult to proceed. Because the problem with TEP repair is, if you have lot of bleeding, then your vision is compromised, and if you have loss of pneumoperitoneum, then also you will have limited space and will face difficulty completing the procedure by TEP method.
Ram sir, just 2 minutes, we'll be back.
Yeah.
Please shift the voice to Dr. Sumanta Dey.
No problem.
Hello.
Yes,
Yeah.
You're on.
Am I audible?
Yes.
Yeah. So दाड़ा देखिए एक बार. Come on. Just hold it. Lock दिता हुआ ना. Just hold it. So I have done a little bit of hiatal dissection, divided the phrenoesophageal membrane. I'll start from where I left. Divide the phrenoesophageal membrane, then come close. Then this is the right crus, just medial border of the right crus. I have created, I have divided the peritoneal lining over there, so I get into the mediastinum. This is the lower mediastinum, lower part of the mediastinum. So you can see this is the right crus. Okay, this is the left crus. So this is the meeting point of the right and left crus. Okay, this is the esophagus. You can see the esophagus. This is the right posterior vagus, the whitey structure, this one. So I have dissected, created a retroesophageal window. So you can see almost up to the that side fundus is visible. Little bit of loose membrane like thing is pending. So what I can do is we can divide it from here, or you can divide it from the other side. So when you have reached up to this, then you can go on to the opposite side. Come out, come out. So this retraction is very important. Then you leave, ask them to leave the retraction, leave it. Then I have, see, upper 1/3, mainly the fundal mobilization is required. So upper 1/3 of the stomach, I will give it retraction like that, and then divide all the vessels. These are mainly omental blood vessels, then the short gastric blood vessels. Okay. So for that, assistant will retract like this towards the opposite side. I will retract like this, not now. And then I have gradually will reach towards the spleen. So these are small blood vessels still which are pending. So I can, with harmonic, very gentle, slow mode, you can divide the structures. Short gastric vessels, you have to be very careful. You can see the spleen, come close. You can see the spleen, upper border of the spleen. So sometimes this part of the stomach is very close to the spleen. So here, luckily it is not like that. So once you divide the short gastric vessels, the spleen will go away from that area. So now, see, assistant, this is the right hand instrument which I am adjusting, is the right hand assistant instrument. So I am giving him traction towards the left. Come out a little bit. Yeah, towards the left, like that. Okay. And then hold. Just hold it like that. Okay, like that. Little bit of persistent pressure. Yeah. Now you can see, come here. See, you can see the pancreas. See, this is the pancreas, mostly body and towards the tail, which part is going towards the spleen. So this is the pancreatic tissue. This is the pulsating vessel. This is the splenic artery, upper border of the pancreas. Okay. So you have to stay away from all these structures, important structures. So what I am targeting is to mobilize the rest of the fundus. You can see. So there is tissue which I can divide it gradually like that. Okay. And then slowly taking care that short gastric vessel, sometimes inadequate coagulation may divide and retract, this short gastric vessels may retract, and then sometimes it is very difficult to control those bleeding. So you have to gradually see all the structures. This is very important area of dissection. Gradually identify all the structures. See, I have dissected on the opposite side. I have reached up to that area. So that retroesophageal window that I have created from the medial side. So you have to connect the lateral and medial both sides. So here, come close. Yeah. So yes, they see, as I keep on dividing, the left crus is getting visualized. So again I will adjust my retraction here, more medial dissection now. So you can see the inferior phrenic blood vessels. This is the inferior phrenic blood vessels. The one blood vessel will come like that along the left crus. You have to be cautious of that. Sometimes from that to right side, kache. Sometimes there is a branch from the inferior phrenic towards the fundus. You can see one blood vessel here. So you have to divide that also for proper fundal mobilization. Again, slow mode, gradually. So fundus should be properly, fully mobilized. Okay, here like that. Little bit of mobilization and little bit of assessing how much mobilization is done. Yeah. So left crus is getting visualized gradually. Come out. Yeah. Yes. So here again the esophagus is visible from this side. So this is the left side of the esophagus. This is the crus, left crus. Okay. So you have to niche down, down, come, this tissue, no, here, this part, yes, come, yes, this tissue can be divided, so that retroesophageal, see now, the esophageal retroesophageal window is visible. So I will take umbilical tape, put it here, umbilical tape now, chhad de, Rohit, leave it. So fundal mobilization is done. Okay, retroesophageal esophageal window is created. খুলে ঢোকাতে সবসময় খুলবি তারপরে এমন করে খুলবি and out করবি, ঠিক আছে? And then the further esophageal mobilization to be done after placing the umbilical port for traction. See, from this side, come close. See the, from that side to this side dissection is done. The retroesophageal big retroesophageal window is created. I'll put a umbilical tape, give retraction at the gastroesophageal junction, pull it, and then further is mobilization of the stomach should be done under vision. Okay, the umbilical tape there. So meanwhile you can shift to Dr. Ram's OT and I'll come back again.
Yes, so so what we have achieved by now is we placed our secondary trocar for right hand working trocar, okay, and where do we place our secondary trocar? I'll show you. Yes, clean the hook. So this is the outside view, okay. This is the umbilicus. At the lower lip of umbilicus we have placed our primary trocar, and there is a line between umbilicus to ASIS, okay, this line. So somewhere between 1/3 and half we see from inside, give me hot water, we see inside and identify the location of the inferior epigastric vessels, and lateral to that we place the right hand working trocar. So we are continuing with 0 degree. At this point we can shift to 30 degree also, but we'll see if we can finish everything with 0 degree, then it will be good. If we find difficulty, we'll change to 30 degree. So now with the help of hook dissector or hook monopolar cautery, we are creating the cave of Ridgius. We have to go in this plane of loose areolar tissues and reach till the pubic symphysis. This dissection is not difficult. You have to just keep on going forward, dividing this plane of loose areolar tissues. Avoid bleeding in this plane. And keep on going till you see the bone. Some fogging, yes. Now we started seeing the bone. It is also called as white house or lighthouse sign. Sorry. Yes. Now one can use scissor for this dissection. Yes. So once you have seen the bone, then we have to start dissecting for our second trocar for left hand. Okay. So for this dissection, okay, I will change to 30 degrees so that we have a better view of of the left side, because for 0 degree we have to tilt the camera and sometimes we don't get the angle. Okay, so we'll change to 30 degree. Meanwhile, you can go to Dr. Sumanta's theater.
So here you can see I have kept one umbilical tape around the gastroesophageal junction, and then I am I have gripped it with a tooth grasper and given the extraction to my assistant. So he will give a traction downward and outward, yeah, so that I can see the whole of the lower portion of the esophagus nicely. Okay, now I am coming on to this area. So you can see this is a retroesophageal into, this is the esophagus and vas held together. Okay, now here. Hi, come close, come close. Now gradually the further mobilization of the esophagus from the mediastinal of structures. Come close, yeah, like that. So one thing you have to be cautious that you will encounter right pleura here, so that has to be swept away nicely like that. See, this is the tongue like projection, you can see this is the right pleura. Okay, so right pleura should not be injured and it should be gradually come close, yeah. So you can see I am just gently sweeping away. I will take it. Change the washer. Thank you. Show me. Yeah. Come. Yeah. So further mobilization of the esophagus. See, you can see the medial aspect of the left crus. Little bit of tissue here you can divide like that, yes, and then further move.
No. Yes. Hello.
Yes, sir.
Yeah, Dr. Jaydev. Hook, please. Hello. Am I audible?
Yes, sir. Yes, sir. Please go.
Yes. So we have changed the scope to 30 degree. Now we are continuing our dissection for our second port placement. Okay. Here you can see at this point, this is called arcuate line. Okay, where the posterior rectus sheath ends, and there is no further posterior rectus sheath. It is a point here where you can directly enter into the preperitoneal plane. Okay, so I am going towards the left side of the patient, right side of the patient, and till this point I am only holding the camera, and with my right hand I am doing the dissection. Okay, so एक्चुअली वायर है यहाँ पर, वायर हटाइए, बाइपोलर रहने दीजिए, खाली मोनोपोलर ही रखिए. हाँ, यस, थोड़ा सा ट्रोकार को हल्का सा पीछे हल्का सा पुल करना है ना, डोंट टेक इट आउट. यस, सो yes, now we have to go into this plane and enter the left retrorectus space. We have to keep in mind that the left inferior epigastric will be there, and we have to stay below it and stay in this plane of loose areolar tissues and develop the space on the left side. Okay, this is the right plane. So we are slowly progressing. At some point we can do some scope dissection as well to create the space and try to locate the space for our left hand working trocar placement. Fine. So give me hot water. Yes. Meanwhile, you can go to Dr. Sumanta's OT. Once I am ready for my second trocar placement, I will call you back.
Yeah. So thank you. This is so I am doing further esophageal mobilization. You can see. Turn to that side, Rohit. That side, that side. See, you can see. I have done the posterior mobilization. Good amount of posterior mobilization, then little bit of lateral mobilization, anterior mobilization I am doing. Okay, so once you release all this soft loose areolar tissue, the esophagus will gradually come out. So you can see around 4 to 5 centimeter is already outside. So this is the aorta, come inside. This is the aorta, you can see the pulsation of the aorta. Okay, and this is the left pleura, I have reflected it that side. Okay, you can do further mobilization. So issue is that so some lower end of the esophagus gets direct branches from the aorta. Multiple short arterial branches will come directly from the aorta. So you have to be extra cautious. So sometimes inadequate coagulation, come close. Inadequate coagulation may, you can see the small vessels. So you have to coagulate it nicely before dividing. So that can bleed here, and sometimes it is difficult to manage. So this is the left crus. Healthy, strong left crus. This is the right crus. Come this side. Come this side. Yeah. So this is the left crus. Now you can see from the other side. So I'll do further separation of the left crus from the lower end of the esophagus, the lateral mobilization, like that.
Sumanta sir,
I will show you the anterior vagus also. It will come once the dissection is adequate. You will be able to see.
Sumanta sir.
Yeah.
Yeah, sir. Intraoperatively, if there is injury to pleura, what would be the next step?
A bit louder, Jajat.
Intraoperatively, if there is an injury to pleura, if
Pleura, yeah.
opens up, what
So
would be
if there is intraoperative injury to pleura, you will develop pneumothorax, iatrogenic pneumothorax, so CO2 pneumothorax. So that anesthetist will say that there is increased airway pressure. So you have to communicate with your anesthetist beforehand that inadvertent injury to pleura may happen, and that can cause airway pressure, increase in the airway pressure. and you have to be careful about that. If there is too much increase in the airway pressure with that, then you have to put a chest drain in between the during the procedure or at the end of the procedure. Come close, left toward left turn, straight. Yeah. So now do the anterior mobilization. So you can keep the chest drain for 1 day or so, then 1 or 2 days, then you can remove that. The CO2 will get automatically absorbed. No need to panic, even if there is inadvertent injury to pleura, but better to avoid it always. So you can see gradually I am dividing all the additions and doing further mobilization here. So
Anterior vagus is coming.
This is the anterior vagus, you can see.
Yes, sir.
Okay, this is the anterior vagus. So you have to push it downwards and do further mobilization of the thing anteriorly. So, but don't injure the anterior vagus. Try to avoid working close to the anterior vagus as much as possible. Push it down and do further mobilization. Separate from left crus from this side also with traction, counter traction, like that. Loose areolar tissue will automatically get separated. Now if you feel, you can just reassess how much mobilization is done. You can see with traction at least 5 centimeter mobilization should be done. So you can see. So how to measure? You just place your harmonic instrument from here to there or any other instrument. Amake bowel grasp de. Or put one 5 centimeter umbilical port inside, just measure, just any instrument you can. Traction, yeah. So here you can see traction downwards. See, so I am placing it, yeah, like that, yes. So I am placing it here. You can see up till C, A, Om Surgical's written is there, right? Written. So up till C or A, G junction is at the level of A or C, you can see, and then tip of the instrument is at that position. So you can take it out. Just take a scale and measure it, how much mobilization is done with a scale. So if I measure it with a scale from outside, 7 centimeter mobilization is done. Okay, so with traction at least 5 to 7 centimeter mobilization, and then without traction, if you leave the traction, leave it, just hold but leave it. See, so at least 2 to 3 centimeter intra-abdominal esophagus is there. Okay, that means your esophageal mobilization is adequate. Okay, now what you can do, you have to bring your esophagus, just show me, lever retraction take to edike asbe, like that. Okay, hold it aram se. Okay, I will take my left hand instrument, I will pull pull the esophagus this side, will put my right hand instrument inside, downward traction, outward, downward, yes. Now you can see I have pulled the esophagus through retroesophageal window anteriorly, and I will see whether the mobilization is adequate. Okay, so what we can do is shoe shine maneuver to keep it in the center to medially edike bas. So in the normal esophageal anatomical lie, you have to do a shoe shine maneuver. So shoe shine is nothing but you have to pull your through instrument, whether it is freely moving, now, and then you leave it. See whether the esophagus, fundus of the esophagus is staying at that position. So you can see it is staying at that position. So that means adequate mobilization is done. So it will not go back. So now I am ready for wrap, but before that I have to do a crural repair. So 20 ethi bond I will take. So take 20 ethi bond. So now again I will push it back to this side. I will keep it in that side. So after crural repair, I will bring the esophagus again. So lift it up, yes, like that. So you can see the hiatal defect, around 3 centimeter hiatal defect is there. Okay, so I will do a crural repair. Green. So there is one, I will show. Just give me the suture. So outside camera, please. Outside camera OT8. No, you keep it inside. Here, focus it on it. So this is 20 ethibond suture. Okay. So this is 20 ethibond suture and 26 mm needle. Okay. And half circle taper cut, double armed. So there are double needle. Okay. Back to laparoscopic view. Back to laparoscopic view, please. OT8. Yeah. So cut. Take this. No, don't touch. গরম জল নিডল হোল্ডারটা দে আমাকে একটু ঢুকিয়ে দিই ভেতরে so I'll take around 15 to 20 centimeter of suture, put it inside through the 10 millimeter port, and then we'll put this camera inside to see. Yes, like that. So suture is inside, you can see. Now I can start repairing the hiatal defect. Take the needle in your hand, right hand. Acha, give me a soft grasper, please. Come. এটা কি আচ্ছা ওকে কাম তোর এটা খেয়াল রাখতে হবে বাবু এটা খোল 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 বন্ধ হয়ে যাচ্ছে খোল উল্টো দিকে খোল বাস that's it hold it like this is very important part nice gentle traction gentle okay now I'll do a crurorrhaphy so this is 20 ethibond suture there is non-absorbable suture okay you can repair it with proline suture you can repair it with ethibond anything so first bite just above the junction of the meeting point of the two crus come close so behind it is aorta so you have to safeguard the aorta by placing this instrument between the medial edge of the left crus and the aorta and then you take it out okay now again hold it come close yeah and then take this so this peritoneal lining over the right crus should be intact that will give you the strength of the repair yes like that just come out a little bit yeah again I will take this needle so be very gentle and smooth try to be very smooth as possible here in this step so what I will give a box stitch kind of thing okay come close so taking it in the backhand and put it come close like this so you need to learn this backhand stitches also so to sometimes it will be of great help again come close yeah so again safeguarding the aorta just good thick bite from the left crus yeah take it out and then pull your thing yes and upore tol ettu esophagus ta yeah like that yes now you can give your knot so keep adequate suture on the other side so that you can see and then hold it left turn little bit of left turn yes yeah hold it keep it in the center of the monitor come close yeah like that now you have to tighten it Yes, and then you can do one more knot.